Here we go. We're going. Hey, there we go. Hey, everybody. Channel launch, advocacy channel launch today with RPH Ally. We have Sean, Kevin, Dr. Richard Harris, and Dr. Bled Tenoe here to talk about the advocacy channel. So I'm going to kick it over to Kevin first because he's going to kind of give us the order. We got three big topics we want to talk about today. So let's get started.
Awesome. Yeah, no, we're so excited to have everybody here. I mean, we have just a really neat team in the background. So some prayers out to Nathan and Roa and some of the other folks that couldn't join us together, and several others that we're really excited to be able to participate and help us out with just building this channel, building awareness, and just bringing people together to have kind of a united voice. You know, it's sometimes really difficult to pull information together. You know, we're in 50 different states that sometimes think differently, do things differently. And we have to really extend ourselves quite a bit individually to be able to pull and accumulate that together and get information. But a beautiful thing is having a network like this, a community like this, where we can all kind of take care of each other and make sure that we're moving the ship in the same direction. You know, we're all kind of rowing on the same side. And so with that, I'm going to kick it over to our three main topics we're going to be addressing at RPH Ally. And the first one that I'm going to bring up, and Dr. Richard Harris is going to help me out with kind of filling in gaps with his background and his skill and ability, are really along these lines. So the first two are going to be payment reform. So payment reform is in the world of, you know, the PBM space, the vertically integrated space. How do pharmacists get reimbursed for, you know, what we're dispensing, you know, the products that we're putting out there, and how do we fairly get reimbursed on the pharmacy side of the equation? Another one that, you know, Bled is here with us, and working conditions. You know, how do we make sure that patients are safe, pharmacists are safe? And the one we're going to right now is clinical and cognitive service reimbursement, right? And so, you know, Dr. Richard Harris has done a lot of work with that in a lot of different spaces over the years. He's a PharmD, MD, so has seen kind of both sides of the coin. You know, we've seen so much pressure from, you know, what's happening from governing bodies like the AMA, for example, and the amount of lobbying dollars they're putting toward, you know, keeping their provider status sacred, you know, which we can respect in lots of ways. But I know there's pressure and there's complaining to be able to get to that point. You know, how can we get CMS to push over the envelope? But there's lots of things that can be done even before that to really showcase and harness what we're doing. So I'm going to pass it over to Richard to talk about a little bit of everything inside of that individual space and give us an update.
Yeah, thanks for having me on the channel. And one of the things I always tell people is I'm a pharmacist first, an entrepreneur second, and a physician third. And I'm very big into the advocacy for pharmacists to be able to practice at the top of their license, because there's a blow up occurring right now in medicine. It's predicted, I've seen as much as 130,000 physician shortage by 2034. Half of which would be in primary care. Primary care burnout rates are 50, 60%, depending on what study you're looking at. And then, you know, most people don't want to go into primary care. You talk to medical students, they don't want to go into primary care. There's other more lucrative positions available. So everything, to me, seems like we're heading off a cliff and no one's really doing anything about it, especially the AMA. They're fighting to keep the old guard intact, but that old guard is dying. You know, during COVID, 1 in 5 physicians said they plan to leave medicine in 2 years. So this is a huge problem. And we all know that true healthcare needs integrative care models. We need everyone working together in their zone of expertise, their zone of genius, to bring us all together. And so I started looking at this problem of, well, how do we get pharmacists to really be more involved in patient care decisions and get them paid appropriately? And we started this journey in 2017, right when Idaho started making some of the law changes. And then, you know, fast forward a couple years now through the work that we've done at Script Health, we're actually having pharmacists do clinical services. And the range of clinical services that you can do under a CPA are pretty vast. You know, as long as that physician is comfortable and you come to an arrangement, that you can do a lot of different things. And then in certain states, you can do a lot just with your pharmacy license. In some states, you have to be credentialed, some don't. You know, that whole area is a mess. I think it's going to coalesce around what nurse practitioners can do. But even then, nurse practitioners may have full authority here soon, because they're lobbying for that. So I fully believe that within the next 5 to 10 years, you're going to see a revelation in pharmacy and more pharmacists being clinicians, less dispensers, and being clinicians in all different fields: pharmacogenetics, medication therapy management, remote patient management, seeing patients and making decisions on medications and ordering tests and acute care, test and treat type stuff, right? Cold sores and flu and all those kinds of things. And so we're seeing that heading in that direction. There are hurdles. Most of it is the pharmacists themselves. We all know that pharmacists are very risk adverse, and stepping into a new role is scary for a lot of them. And so we've worked on a lot of education, preparation. I know, being a pharmacist and a prescriber, the gap and how to bridge that gap. And we've worked on a lot of that as well, getting the mindset right and being comfortable stepping into a role that everything is heading towards.
Is that a big start right there, Richard, for us? I mean, so some of my background that you already know, buddy, is with IHS, and IHS and the VA have really leveraged their pharmacists for quite a while, utilizing them in collaborative practice agreements and really practicing at the top of their license, so to speak, with utilizing those CPAs so that they can see patients, they can do chronic disease state management, they can order labs, they can do all the things that you would expect from a provider to be able to do for an individual patient, and utilize the skill sets and training and background they have. And then I've also seen, lots of pharmacists that are less risk averse going out there and fighting for the ability to serve some of these clinics and medical facilities in their area through incident to billing and other modalities under a CPA, so they can take advantage of the things that are out there. But is that really the big step for us, Richard, in terms of like talking about the nurse practitioner route, looking at where nurses were before the nurse practitioner kind of invention to where they are today, with some of them in multiple states, like my state of Washington, that they're totally independent practitioners with practitioners underneath of them. Is that the first step for pharmacy? Is it really we have to leverage the opportunities that are ahead of us?
Yeah, absolutely. I think that's the exact playbook that we should be playing out of right now. Is exactly what nurses did to elevate themselves. And now, most people, they don't know if they see a nurse practitioner that it's not a doctor, right? The experience on the patient side for a lot of things that they're seeing these nurse practitioners for is seamless. And I think that's going to be the case with pharmacists. And I'm glad that there are, mavericks out there who are pushing the limits, who are advocating for this, who are doing exactly what we're able to do at the legal limit, showing the value that pharmacists bring. Because, ideally you would have a physician diagnose, and then you'd have a pharmacist be involved with coming up with the treatment plan. Like, I'd rather have a pharmacist suggest what medication I should take than a physician. I know that because I know the education that physicians get on medications, and it's paltry, poor, horrible. I mean, I could just go on with all these adjectives. I used to take a 100-question pharmacology test in medical school in 5 minutes, and I'd be out of there because it was so surface level compared to the education that I got as a pharmacist. So, that would be a great model, that integrative care model where everybody is doing what they do best. And there's plenty of slices of the pie to go around for everybody. We're not stepping on anybody's toes here, right? You go to a medical clinic and walk in, how many people are in the waiting room, right? People can't get access to high quality care. And that's not even including rural areas where they may have to drive hours to see a physician, where there's a pharmacist 5 minutes away. So all of these things to me are saying this is a no-brainer. This is where we have to head. We just have to make sure that we are advocating for ourselves and doing what we need to, talking to the right people, getting in groups, getting organized, because pharmacists aren't very good at being organized. They're not really good at banding together. No one's, outside of what we're doing here, no one's really tried to get a whole group of pharmacists together to move in a single direction. The nurses were very good at that. And that's how they were able to expand the scope of their practice. So I think there's a lot of excitement right now, a lot of really bright days ahead. And I will continue fighting for pharmacists, as long as I possibly can.
I love
Solid
it.
goal, Richard. Yeah.
You mentioned a path kind of forward, Richard, and this will be the last one before I know you have to go and see a patient, my friend. But the question really for me is this, we look at the nurse practitioner pathway, and some of the big success moments for them was what you just mentioned of banding together, finding ways to become organized and recognize, what they had to do to be able to bridge the gap from current status to future status. One of the other things that they did that is pivotal was they partnered with physician champions, folks that looked at them and said, you guys can do this, and you can help out my patients in these areas, and I need you. Where do you feel we are right now, Richard, with that? Because I feel like sometimes as a body of pharmacists, you hear about what's happening with American Family Physicians, you hear about the AMA, you hear about all the negativity, but then you go out and practice. And for me, like, I can remember, Richard, being in the hospital and providers looking at me and saying, "Hey, Kevin, can you please just pick the med that you want, put the order in, and then just tell me what to do?" And like, that's the kind of real life relationship that's had, as opposed to like, the negative light that's being shined from some of these large organizations. But I wanted to hear from you, Bud, when it comes to next steps of pairing these folks together. Where can we do better on the pharmacy side to help physicians to be able to partner with us in those collaborative settings?
I think the advantage that nurses had is that they had always closely worked with physicians, right? And so physicians clearly knew skill sets of nurses, right? It's clear, a rock star nurse, you didn't do anything. Like, they made your job completely easy. When I had a rock star nurse in the ICU, they would, I'd be like, okay, just tell me what you need me to sign. Right. That was it. I was just sitting there. Just tell me what you need me to sign. All right. Because I completely trusted them. They did everything correctly. They assessed the situation correctly. The meds were all correct. Dosages were it was easy. And so nurses had that advantage of that close collaboration with physicians before. And now, most physicians who run an outpatient practice say they couldn't practice without their nurse practitioners. Right. They just couldn't. They couldn't service all their patients without them. So I think one of the things that we need to do is, most docs don't really understand the depth and the knowledge base that pharmacists get coming out of school. They think it's, pharmacists just, dispense meds for the most part. But there's so much more than that we learn in school, and our capabilities are a lot higher than that. So I think part of it is those mavericks I talked about who are leading the way, who are working with physicians, are showing that, hey, this relationship has a lot of advantages for me and a lot of advantages for my patients. And so the more we do that, the more that becomes commonplace, the more we work together, the more these physicians are going to be okay with offloading some of these things onto pharmacists, right? So I think that's the major thing, is just continuing to foster these conversations, these interactions, continuing to show our value in the clinical space. And I think year after year after year, that's becoming more apparent. Also, in schools now, there's typically a clinical pharmacist working with physicians. So, the younger generation of physicians is very adept at working with pharmacists because they're used to it. And, I always tell people, who's the smartest person in the hospital? The clinical pharmacist. Because they know everything. They know every new study. It could just be published like 2 hours ago. The clinical pharmacist has probably read it. All right. And already like coming up with plans to help implement that and help patients. So those are the ways I think that we really get this movement going, is by not being afraid to show physicians what our value is, which is kind of funny. That's the whole reason I went to medical school. The whole reason I went to medical school, because I was pissed off and I wanted to show these physicians what a pharmacist could do.
Amazing. No, I love it. I love that fire. I appreciate your partnership and your camaraderie and everything that we do. And I hope you have a blessed day, my friend. And thanks so much for joining us, Richard.
Yeah, thanks for listening to me ramble, guys. Y'all have a blessed day.
Thank you. Talk soon.
Perfect. Now I'm thankful for Richard there, and I think there's lots of things that we can learn from, having that collaboration. And I feel like someone that's been learned lots of lessons in collaboration that she has passed over to me is my dear friend Bled. And Bled has learned about collaboration from a much larger scale. You know, we're not talking about one professional working with another. We're talking about very large governing bodies and the way that they kind of dictate changes and movements inside of society and inside of some of our health systems, especially in the retail pharmacy fronts. You know, what we can do to really protect our coworkers, what we can do to protect our patients, you know, where those kinds of lines draw, and has done some incredible work. So a huge thank you to you, Bled, on the things that you've done. You're one of the most humble people that I have ever texted with. Like, it's ridiculous. Sometimes I'm like, why is she saying this? Like, she's done so many wonderful things, but I appreciate that humility. Like, it keeps all of us connected. It makes us all feel special because you give that off to other individuals. And so I'm very thankful for you. And with that, I wanted to pass over, though, the work that's been done. Like, we've seen a couple positive things happen of late that you've mentioned on social media, and I know you're active and kind of helping with. So I wanted to pass it over to you on the other topic we're talking about at RPH Ally, which is working conditions for pharmacy.
Yeah. Well, thank you for having me. Sorry about the noise in the background. My tablet is having a small meltdown this morning, so it's been a rough day. But yeah, I mean, it's been a very slow journey, and we all know that changes that do not happen really fast. You just have to be willing to take the ride. However, in this climate where we're having so many issues in terms of safety concern and well-being and everything, you want things to be fast, but unfortunately that's not really how it happens. So I want to first say a lot of courage and a lot of empathy for our frontline worker, technicians, pharmacists. We really are having a hard time to be able to bear those working conditions, as we're trying to move, toward the right direction, but also, unfortunately, it's really slow. So yeah, we've seen tremendous changes happening in the last year. I would say the biggest one has been the amount of media attention that has been happening on working conditions, which I mean, somebody correct me. I don't think pharmacy has ever had that much of attention on. And ever, we're talking about major news outlet like, the Wall Street Journal, Bloomberg and New York Times and AP, recently. So there's been a lot of media attention, unfortunately trying to correct the narrative, as far as like whether there's a shortage of pharmacists or technician or not, and really trying to fight to make sure that the truth stays out there. And that's important, and unfortunately, as we are trying to change narrative, we don't have access to those big media because we are not huge, and so those big corporations have the charge and also have the access to be able to push the narrative. And so my big ask right now is, if anybody has any type of contact in the big media, when I mean big, I mean something like CNN or ABC, where we can have a larger portion to talk to this kind of issue, so that we can really go out there and tell the truth about what is really happening. That is not an issue of shortage, it's not an issue of the fact that we're having a pandemic. All those have been happening before COVID. And so yeah, so a lot of media attention again, a lot of different board of pharmacy taking really great actions. We saw Oregon going through a large major lawsuit against one of the major corporations. We also saw them recently coming out with a new revised law that pretty much will give pharmacists the power to cancel appointment, to cancel vaccine, and to even close the pharmacy down if there's any type of safety concern based on workload. A few months ago, we saw North Carolina bringing with a new status again, saying that the pharmacists have the power to make decision, and meaning that the permit holder cannot override decision of the pharmacist, which is huge, shifting the power back into the hands of the pharmacist as well. And Oklahoma and Ohio, I just realized that Ohio already have the law about the anti-retaliation is actually already active. It's not a new law. It's been in the status since I think last year. And so now it is against the board of pharmacy rule for any employer to retaliate against pharmaceutical technician if they were to file complaint of safety. And I believe in Oklahoma we are hearing, we're having public hearing this month. I'm sorry, in February, to see what, but it's sure that it's going to pass, So we're seeing little things happening across the state that, once again, it's just really packet here, and it would take a long time to see a full effect. What I've been really wondering about is, what are we doing on the federal level? How are we addressing the issue of working conditions in the federal level? And when I've been sending email to the senators here in Oklahoma, the answer I get back is the fact that this is a very much a state to state concern, and so the board of pharmacy are really the one that need to be impacting and regulating those working conditions. But again, it also comes with association taking the charge to advocate, for those changes, because many board of pharmacy do not have the power to change the law within the state. It has to come from a law that needs to be written. And this is what I'm having discussion with association, whether it's social media, asking them, you have the resources, as individual pharmacists don't have power to lawmakers, but as an association, when you send out a request for a meeting or you send out a charge for a concern, because you are an association, that carries more power and that carries more interest than individuals sending 20, 30 emails, which is basically what I do here, And so imagine having an association taking that charge, and seeing and bring about all the laws that they think that we need to see in the profession. That can really shift, because if we're waiting on the federal level, it might not happen. It really has to come state to state. And what I have realized is that board of pharmacy in the state like to see what other has done and see how they can use that within their own state. So if a state is not doing anything, it's really hard for an association to come or an individual like myself and say, this is what I propose. The first question will be asked, where has it been done? And so we just need really to again, it's really, we need to realize that this is not a one person job. Pharmacists to be involved in their associations and to be involved with going to meetings, but ultimately changes come from the entity bodies, which are the board of pharmacy and association. Those are those who have the power to really make those changes. And I really want to give a shout out to so many associations who are really, really working so hard to really address those issues. Kentucky or Tennessee or California, or North Carolina, and so many in Oregon, so many associations are really going on full power to really make sure that they're bringing out the voice and the concerns of pharmacists across the state. We have so much work to do, really a lot of work to do, and once again, binding together, like Dr. Harris was saying, we are known for not binding together. We are very individual in what we do. Is your problem, my problem, all that. But here's the thing. We are seeing report of working condition within the health system. It has now migrated from retail to other places, which I have predicted at the beginning that it was not going to be contained only in the chains, it was also going to go to other sector of pharmacy. So now we're seeing the spread out of patient concern, and lack of safety. How do we come back together as a profession, to be able to not just talk about those issues, but really think about ways to implement and ways to be able to make changes. Advocacy can be private, which by many sending emails to your lawmakers, or he can be also very public, like some of us, but we all have a role to play in this. We cannot afford to remain on the sideline. We cannot afford to remain quiet. We cannot afford to just be, this is not my problem. It would take all of us to do this. And so if a little bit of what is happening, what we can really all do.
Tell me this, Bled. Like, I love the way you ended that with needing all of us, and really pulling in what Dr. Harris was saying is sometimes it needs all of us and across multiple lines, to happen inside of the provider status. Here's one thing that I've kind of addressed before, and you and I actually haven't talked about it, which is funny. But when it comes to who cares, right? I mean, this is only happening to people that work in these kinds of pharmacies. Like, it's not happening to me. What's the reason why, if you are working as an independent pharmacy owner, you're working in an independent pharmacy, you're working in an ambulatory setting, you're working in the hospital, that you should care about these kinds of things for our profession? Can you give us a little rundown on that? Like, what's the mindset that we should take on to be able to help our colleagues and ourselves?
Yeah, absolutely. The first thing I take is the fact that first I am a patient. Your family is a patient. So whether you practice in a community setting as an individual, you are affected because you have loved one who are a patient. Maybe granted you feel at your inpatient pharmacy, but your family members or your friends do not. So if you have someone that you know that is in dying need of a medication and he's taking weeks or days to get it because their local CVS and Walgreens is not adequate staff, you have someone close to you that is affected as a patient, For instance, when we take the case of Oregon, the complaint in Oregon was the fact that many patients were discharging out of the hospital were going back because they could not access the medication. So the patient that you are treating in the hospital while going home, they're going back to the hospital. If you are for Medicare, that's money that you have to spend to take out this patient because Medicare has a rule of how many days you can readmit a patient for them to be able to pay for the expenses. And only that, as a physician also, if you are not able to call in new prescription, if you because nobody's picking up the phone, even if you leave a voicemail, and nobody can read and can listen to the voicemail, so your line of patient care is also affected. Secondly, if you're a pharmacist working in an ambulatory care setting or a health system setting, and you're trying to get medication history, trying to get allergies, you don't have the whole picture to treat your patient. So here's the thing: it might be happening in this setting, but the entire process of how to care for a patient is broken because community pharmacy is at the center of everything. No matter what people say, if you remove that, you have nothing. And we've seen it more than ever that if it was not for community pharmacies, we would not have been vaccinating almost the 267, I don't know how many million vaccine given. So they're all the first people you see before you make an appointment. They're all the last people you see when you come by. They're all at the center of everything. When this base is broken, everything else on the tree is falling apart. And I think we have yet to realize that community pharmacy is the root of pharmacy. No matter our opinion of what they do or they cannot do, they're all the root. And so the root is dying and is slowly coming on the tree. And there's this decay that we're all feeling that we're not seeing, but it's actually there. And I feel that it's going to crumble. And I know we have no traditional way to practice. There's be entrepreneur and it's all that. I get that. Don't get me wrong. But once again, regardless, you are affected one or the other.
I love it, Bled. Like, that's so well said, because the entire system is being impacted. Like, the way that our loved ones are being cared for is impacted. And I feel like I heard a pharmacist, an independent pharmacist, say once, community pharmacy is clinical. And I can't agree more with that. That's where it starts. Like, people do not want to live in acute care settings. Like, I hate to tell all of my colleagues that work in the hospital and everywhere else, no one wants to see you. No one wants to be there. We don't want you to be there. The healthcare system they don't want you to be there because it's expensive and it's costly and it takes away from quality of life. But what keeps people in their homes and keeps people from these acute care settings? Community pharmacy. And if we don't protect that, if we don't allow them to do their jobs the way that they need to do their jobs, we're doing a disservice to every one of our communities. And I love the way you talk about it being the root, because it absolutely is. Like, that's where our communities get centered. When they need advice, when they need someone, where do they go? They don't go to these other settings. They go there. And when we, all these other allied professionals, need information about our patients, I don't call up somebody else specialty pharmacy, down in Timbuktu. I'm calling my community pharmacy right there in town and asking, how is this patient doing? What have they picked up their prescriptions? What are their current med lists? Do you know anything about their OTCs? So even getting a bead on our own patients to take care of them well, all lives.
Absolutely.
So
I mean, you think about it, I'm sorry, I didn't mean to cut it off.
You're good.
Our in our oath, the core of it is patient care. So it means that you have a duty to value patient care regardless of where you practice. So if patient care is being affected within a sector of pharmacy, that that oath is not being followed. So therefore, you should be concerned that we're having an issue of patient care there as well. If my patient are going to the hospital and they've been not be treating properly, or they're lacking some type of proper therapy, I should care about that, because it goes against what I sworn within my oath. So the idea that patient are not being treating and they're not getting optimal care when the community pharmacy should be affecting all of us as a profession. If you are a practicing pharmacist, if you took that oath, it should affect you. And so my call is, regardless of who you are, regardless of where you practice, whether you are a technician or a student of a pharmacist, you are an association. I I am in dismay that some associations do not even address working condition as a topic or
Yeah.
discussion in their meetings and the conference and anything. This is a burning fire that needs to be talked and discussed and triage and come about solution. I is I think of this as the fact that, for me, like you say, how much do you care? I don't work in a retail pharmacy, so I'd be like, well, peace out. But it's all about how much do you care for other people. That's really what it boils down to. And I hope that we have enough compassion. People, I say, life is revolving all the time. You are never out of the wood until you're dead. So do not think of yourself that this is not an issue that is going to affect you one day. It's all about compassion. It's all about grace, and we all need to come together
Amen.
to be able to look at those issues and make sure we're pushing the profession forward.
I love it. No, thank you so much, Bled, for the update, for kind of that call to action for folks, and just, I mean, call to be together, to
Yeah.
recognize how we can really help each other. And I think when we're trying to help each other, Sean, here's one thing, buddy, that we've been like, it feels like beating the dead horse. I don't mean to be negative about it, but that's exactly how it feels, because I think since I was a student, even coming into pharmacy school, the talk has always been big bad PBMs. Like, that's always been the case, and we have to be able to change the way we're getting paid. These DRR fees are, pulling me down the tank. But there's some really interesting things happening right now in the space that aren't related to that same conversation, that you and I have had some other conversations with, leaders in these spaces that are trying to do things differently. So, Sean, what are we going to do at RPH Ally when it comes to kind of addressing the payment reform space? Because I know that we all want to get paid for clinical services, which I agree. But part of what we do is connecting folks to the product. Like that's a big piece of pharmacy in general. If it's compounding, if it's specialization, if it's infusion, whatever it is, we're trying to connect people to the right products, right? And so getting reimbursed on that side of the coin, I think is a very important fight to have and to recognize. So what are we trying to do, buddy? What are some things that people should know about, and why should they participate in the conversation?
I mean, it's really related to what Bled just said too. I mean, from my experience, it's all smoke and mirrors all over the place, right? People are being lied to every single day, like the decision makers, on how they can save money by going with this company, right? But it's all a lie. And I've seen it inside. It's a lie, right? It's you're not saving money. I'm really sad. I'm in prayers for Nathan that he couldn't be here today, but because Nathan Gabbard started his own transparent PBM because he was sick of all of this, right? And then it still affects the working conditions that Bled's talking about. And Bled, I just want to call it, I love how you took that oath to a new level, right? I never thought of that before, but I've always been like, okay, this patient, and then the advocacy part. And it's like, wow, it's like, no, wait a second. We have to advocate for everyone, for the profession. That was solid gold. Anyways, so yeah, and this one's really tough. I mean, at a national level, like, there's a lot of stuff going on as far as regulations trying to, control the clawbacks and DIR fees. But I think at RPH Ally, we're not lobbyists like that. But we're really good at connecting people. So we want to connect people. We want to educate people. We want to connect people to the Nathan Gabberts and the PBMs that will help employers actually save money and have their employees and team members live healthier lives, right? And they're not just going to be collecting automatic refills every 90 days, or it's actually more like every 67 days, right? If you think about it, like that's how things happen. They just pump them out. They just want you to take that automatic refill because it's better for the bottom dollar. But anyways, lots of stuff. That's it. Kevin, Bled, anything else on that? It's kind of a rabbit hole we could go for hours.
No, I think you kind of hit on the big things that are kind of interesting to me, Sean, right now is just, we're seeing stuff from the Mark Cuban Cost Plus company. There's Blueberry Pharmacy that I know was doing some innovation even long before that and looking at what true like cost plus models are looking like in subscription models. We're seeing more like actual membership kind of models fall in space that's really getting rid of PBMs altogether, and going toward this cash-based world. Interestingly, the insurance space hasn't necessarily caught up to be able to allow patients to feel free to participate in those kinds of settings for everyone, which I think there's some work to be done on that side and being able to recognize what insurance plans can do to be able to allow that kind of freedom for their patients and the level of choice that we should have. Inside the transparent PBM space, there's not all good actors there either, and I think that's the other piece that we can do together is really hold some people to the fire, and keep people accountable when they're trying to take care of patients and they're taking care of our communities. Because I think it goes back to exactly what Bled said. We've got to care. So if we care enough to be able to say, these guys are doing a fantastic job, and if you can connect your employers with these bodies, it's going to be better for the independent pharmacies like in your guys' community.
Yeah.
Fantastic. Like that's the kind of information exchange that we can have and be able to use our networking and connections to bring people in that are going to be more impactful for us as individual pharmacists, as pharmacy owners, and as patients, for some of those things to happen. Because if we want innovation to occur and payment models to occur that allow us to really practice to the point where we're helping patients and not just pushing things across a counter, we have to find the right partners and we have to find the right incentives in order to do that. And I think, you said it with smoke and mirrors, Sean, earlier, that we can't have smoke and mirrors. Like we have to have a transparent way to be able to evaluate, who's doing well for our patients. So there's my 2 cents. Anything to add to that, Bled?
No, you're correct. I like the intention of caring. I think that's really what is at the basis of everything. If you care enough, you will be driven to do something once again, whether it's privately or it's publicly, at the end, I really believe that we as a profession do need to come together because there's just too much separation. And then I think there needs to be a lot of healing in between each other, because I believe that we have cross lines in how we treat each other. I think we always find a way to, what's what I'm looking for, to make someone else feel smaller in a way. We done it to each other. This is your problem, this is not my problem. I'm better than you, I'm smarter than you, and all of that. All together, we are pharmacy. We care for patients. We go the extra miles for them, and we care for each other. This has to be enough to realize that if you are suffering, I am also suffering. If you are hurting, and if you are winning, I am absolutely winning. There are no small or big contribution, regardless of how much you can do. We can all do it together.
I love it. Awesome. I don't think there's any better way, Sean, for us to sign off than just what Bled said right there. I think that's our real call. With our PH Ally, what we're trying to do is connect people, make meaningful connections, and kind of open up conversations so that we can utilize those little wins to make big wins, for us to be able to multiply our efforts together. And so if you are interested, if anything has appealed to you here, even if you're not, still join us. Come to our PH Ally, bring all your registration information that's currently available. And then what do you do next, Sean?
Yeah, I would sign up, rphally.com, and then go to channels, or we have support and education channels. That's where you're going to find this advocacy channel. And we want to hear from you. Like we want to, now this isn't Reddit, right? We want to hear from everybody. And again, there's one of those things too, where I did call out this morning, if it's If you are more of the bashful type, or you're scared of retaliation, right, Bled? Just email us at info@rphli.com, and we can post whatever comments or questions or thoughts.
Or just
that you may
email
have.
me directly, and then I can do that.
Or email, email Bled too.
I'm the
Bled
holder of everybody's secret.
Well, say that again, Bled. I cut you off.
I mean, I'm the holder of everybody's secrets.
True. Yes, email Bled. So you can also email her at Bled, BLED, Bled at rphli.com, or fightingforpharmacy@gmail.com, right?
Yes. Mm-hmm.
Either or. Okay, perfect. Awesome. Hope to see you there. Thank you so much.
All right. Have a good one.